implement the triple aim. I would like to briefly review the agenda for this webinar. First, I will explain how to submit a question to our presenters. Then, Rebecca Roper, Director of the Practice-Based Research Network Initiative at the Agency for Healthcare Research and Quality, will introduce today's presenters. We will then hear from our presenters about their experiences measuring practice transformation. After each presentation, we will have a brief question and answer session. We will have a question and answer session with all presenters after the final presentation. At the end of the webinar, I will explain how to obtain CME credit for participation in this webinar. Please note that after today's webinar, a copy of the presentation slides will be emailed to all webinar participants. If at any point during this webinar you have trouble hearing our presenters, please try hanging up the phone or headset and dialing back into the webinar. Please note that none of today's presenters have financial relationships to disclose. Additionally, presenters will not discuss off-label use and/or investigational use of medications in their presentations. I will now explain how to submit a question. To submit a question, you may use the GoToWebinar control panel. Type a question under the Questions section and hit Send, as shown in the screenshot on this slide. You may submit a question at any time throughout the presentation. During the Q&A sessions, as time allows, your questions will be read out loud and our presenters will respond. I will now turn the presentation over to Ms. Roper.
Good afternoon. Thank you so much for joining us. We have a really notable team of presenters. We also are quite excited about the size of the audience. We have nearly about 900 people who have expressed an interest in this presentation. These five fine researchers and practice-based research networks. I will give a brief introduction to each of them before we begin. And you can see our lovely Dr. Chet Fox, who will be your first presenter, and he is up in, I'm afraid, too cold in Buffalo, New York. He's the director of the Upstate New York Practice-Based Research Network, and he has been engaged with translating evidence into practice for almost a decade and a half, and I will say, what's not on the bibliography is he is a wonderful resource for the PBRN Resource Center because we ask him for connections and information himself, and he is a real facilitator of connectivity for all types of projects. So we're delighted to start off the presentation with Dr. Fox. He will be followed by Dr. Lynne Nemeth, full professor at the Medical University of South Carolina, a nurse researcher, and a primary care practice-based research investigator who has established advancements in PBRNs with respect to translation of research into practice, particularly in the use of health information technology. Just as a note, she was also one of the first folks who had a study that we represented in the Health IT portfolio with a wonderful overview of e-standing order. So she is a trailblazer herself. And then we have our third presenter, Dr. Zsolt Nagykaldi, who is now the Director of Research in the Department of Family and Preventive Medicine at the University of Oklahoma Health Sciences Center and is the Research Director of the Oklahoma Physician Resource Research Network and is, like many of these presenters, ever active in different programs and discussions across the PBRN community, and we look forward to his presentation, which will be shared with Dr. Paula Darby Lipman, who is an active member of the CocoNet 2, which is one of our esteemed P30s, who is the director of their data coordinating center. She's been quite involved in working with various activities of Oklahoma City with respect to Faithful, Fit, and Strong Collaborative, and she's also involved with different community-based outreach programs and has a wonderful long-standing relationship with both the Oklahoma team and others throughout the PBRN network. And then we have our fifth presenter, Dr. Rodger Kessler, who we understand was so excited to be part of this presentation, extended invitations to various organizations in the mental health field. We're glad to have you all join us today. Dr. Kessler is the director of the Collaborative Care Research Network, which is a sub-network for the National Research Network, and he is distinguished behavioral scientist. So we're so glad to have him on today. And as you'll see at the conclusion of the presentation, for those of you for whom this is the first time to participate in the PBRN-sponsored National Resource Center-sponsored activity, consider joining us on our PBRN listserv. We'll address that at the end. So as I said, we have 5 presenters, but to help us all understand who has joined us today, we are going to issue a polling question which asks you to describe your experience with measuring and evaluating practice transformation. And there are 4 options. Christina, could you issue the polling question? And you can see that there are, I hope you're all seeing that. We'll begin to see the results. The 4 choices are, I am not involved in practice transformation or measurement evaluation. I am involved, but practice transformation, but not measurement evaluation, and here we see. So please do participate in the polling. This is helpful for both the 5 presenters today, and evaluation is necessary for us to continue these types of gathering meetings to see what we can provide to meet the needs of our community, our PBRN community, and its extension. So what I'm seeing happening, we're at about 3/4 have voted, and 27% say that they're not involved with practice transformation. So I'm glad we have some newcomers to this discussion. 21% say they're involved in practice transformation but not measurement evaluation. And the third more populated group is I have some experience measuring and evaluating practice transformation. In the 4th category, which 14%, I have participated in the design and the conduct of practice transformation evaluation. So we have a nice spread of experience represented amongst us. As we go through the presentation, there will be different polls, and I encourage you to participate. And with that, Mr. Fox, Dr. Fox, excuse me, I'll turn it over to you. Thank you, Chet. Perhaps Dr. Fox is, we're having a little challenge with audio. I will say...
It helps if I unmute myself.
Well,
Hello?
Excellent, Dr.
Can
Fox.
you hear me now?
Yes, we can, sir.
I forgot. Yeah, thank you for having me, and thank you for the kind introduction, Rebecca. Basically, as we started to try to translate evidence into practice, and people started talking about practice change and transformation, we said, how do we measure it? Let's see. Don't tell me. It's not letting me move the screen down. Am I the organizer?
Yes, you should be able to advance the slides now.
This is not good.
We can advance the slides.
Why don't you advance the slides, because my computer seems to have frozen.
Sure, no problem.
It's that polar vortex.
I don't know. Next slide. There we go. How this got started. As I started getting into translate evidence into practice, it was at a conference that Kevin Peterson presented his work on a large NIH grant that he was working on diabetes care. As he tried to improve diabetes care in primary care offices, he said, how do we know what works? So the first thing he did is he went and did a literature search on the modalities that would be effective. And he found evidence in the literature, this is in the mid to late 90s, of 9 elements that he cleverly put into the acronym TRANSLATE. And once he put it into the acronym of those 9 elements, he did a successful randomized controlled trial with over 8,000 diabetic patients that showed improvement. Now, he implemented in the items all 9 elements of the TRANSLATE model. And I took that and modified it a little bit, and I'm using it for a pragmatic clinical trial, comparing point-of-care computer decision support to facilitated point-of-care computer decision support. And from that, we said, okay, the 9 elements make a lot of sense. Can we start putting numbers to it? Can we start using it as an actual measurement tool or a formative analysis iterative tool, which we're still working on? I got excited about the TRANSLATE because when I thought about the 9 elements and I thought about my work with practices, usually I could point to 1 or 2 of these elements that either were facilitating or created huge problems in a practice transforming. Next slide, please. So here's what the acronym means. T stands for target, R stands for reminder system, A stands for administrative buy-in, N stands for networked information system, S stands for site coordinator, L stands for local clinician champion, A for audit feedback, T for team approach, and E for education. And we'll be going through these in a little more detail now. Next slide, please. When we're talking about target, we're really talking about goal setting. And first of all, there are 2 problems that practices get into. Either they set no goals at all, or they set too many goals. We're going to do 13 quality measures on diabetes and 5 on hypertension and 6 on lipids. So you can have clear, measurable, and feasible goals, but have too many of them. So are there the right number of targets? Are there the right number of goals? And are they clear, measurable, and feasible? A clear goal might be improved diabetes care, but without defining what that means, it's not going to help you. Or you could have, say, we're going to get 90% of our diabetics' hemoglobin A1Cs under 7 by next month. That would not be a very feasible goal. Next slide, please. Reminder systems, we're really talking about actionable information at the point of care. This is where, and this is sort of the promise of the EMR and functionality that we want out of the EMR that we often don't get. And I know there are pop-ups and reminders and other things, but for this to be workable, it really needs to be patient-centered and not disease-focused. On the right is an example from an EMR that turns out is very highly rated. Nationally, it's a local niche product here in upstate New York, where they have a number of disease-specific algorithms within. They have a number of disease-specific algorithms within the EMR, and as part of that, they create a patient profile, where red will be things that are either out of goal or out of control or not or due. Yellow will be it's coming up that month, and white will be done. And you can even click on. Like, for example, if a mammogram was done 6 months ago, it'll give you a click for a report. So this makes for nice information at the point of care so that you can give it to a nurse or a team member, and they can give the flu shot and pneumonia shot, and it will be specific for each individual patient. Next slide. Administrative buy-in. When I did a literature search on administrative buy-in, there wasn't a lot of evidence that it was important, but there have been a number of studies which showed that when the people who controlled the resources didn't commit the resources, the project didn't do well. There was one large study where a person got the grant funds and had to refund the money to the NIH because the doctor said, okay, we want to do this study. They submitted the grant, but the administrators at the hospital said, there's no way we're letting you do that. So having the right people with money and personnel supporting it is really important. In a small private practice, that's often also the lead clinician, but in large organizations, it's commitment of nursing time, it's commitment of staff time for training, etc., things I'm sure you've all experienced. Next slide. When I talk about networked information systems, I'm really talking about population health. We're talking about creating registries, and preferably we're talking about creating queryable registries. And I put on the slide an example of one system where they have reports where you can filter it. Give me all of Dr. Fox's patients who are diabetic, hemoglobin A1C over 9, or give me all of Dr. Fox's patients with congestive heart failure who haven't been seen in 6 months. And you can say what elements, what data elements you want to come with. So registries become a difficult term. It can mean anything from a list of patient to a very smart communication tool. When I think of a population health registry, I think of something like this, where there's not only the patient, there's the clinicians, it can be shared, and you can add whatever data elements you want. So let's say I have 7 data elements for diabetes, I can add an 8th element for like PHQ-9 or whatever. Next slide. Looks like I skipped one. Could you go to the next slide? Next one. No, what did feedback? Go again. Go again. I forgot a slide. Go up to the next one is site coordinator. And that's really about local accountability. It's okay for the doctor to say we're doing it, but who is the staff person, whether it be an RN or office manager or other person who's going to be responsible for actually creating the workflows and getting the work done. Next slide, please. The L stands for local clinician champion, and we changed it from physician champion to clinician champion because we found that NPs and PAs have done a good job with this. In some diabetes studies, the clinician champion was a certified diabetes educator, etc. The role of the champion is similar to the role of the Pope. They don't have to do anything, they just have to bless it. So often in an office, you need to have the doctors buying in and the doctor saying, yes, that's a good idea, so the staff knows that they're able to do these things. For clinician buy-in, you often need explanation of the evidence base, which is why we use a lot of academic detailing when we do practice facilitation. It doesn't have to be the MD as I described, but people have to say, why is this important? How does this help my patients? What's in it for myself and my patients to improve? And you need the clinician champion to really help get the staff on board. Next slide. Audit and feedback. I've become a real data geek in my old age because, one, I found it very hard to get good quality data easily, but I also found that without good quality data, you didn't know where you were. There are 2 types of audit feedback reports. One is a longitudinal report where you look at an individual measure and look at it quarterly and look at the change over time. Let's go back to diabetes, for example. And in the diabetes example, that you're looking at percent of people at goal for hemoglobin A1C. So you'll have your quarter 1, quarter 2, quarter 3, quarter 4 results, and you can track progress. The other report that we've been giving, in addition to a longitudinal report, is what we call a benchmarking report. This is out of our CKD study. We have a number of practices within the study, and so for each measure, the the individual practice is in red, and all the other practices are a different color bar, so that people can see where they are. This does two things. It gives people a sense of where they are versus other people nationally, but it also gives a sense of where the maximum is. We did one study with DARTnet where we had 90 different practices, and cholesterol control in the top three were 69%, 70%, and 72%. It sort of tells you that there's sort of a real-world maximum in current systems in terms of being able to set goals. And people seem to like the benchmarking reports, and we hope to, in our current study, to get the benchmarking reports down, not to just the practice level, but individual doctor performance level for the practices that want it. Interestingly, we found most practices did want individual performance reports, but there were some that said absolutely not. We want to view this only as a team. So it'll be interesting to see how that shakes out. Speaking of team, next slide. Team approach. If there's been anything we've learned about patient-centered medical home, it's the importance of people practicing to the top of their license and working on teams. Based on the idea of sort of patient safety in the airline industry and Toyota quality circles, is that everyone has a voice, and you solicit it, they're non-hierarchical in nature, that everyone contributes for the benefit of the team and the good of the patients. Then the other thing that a lot of practices have liked very much is huddles. These are sort of micro teams within a practice that meet briefly before seeing patients. Next slide. Education involves all sorts of things. It can be academic detailing, collaborative learning groups, in-service, CME. Academic detailing, collaborative learning groups we have found to be very helpful in PBRN work. There's an example of sort of a video webinar sharing, similar to the kind of thing that we're doing today with small groups where people can actually see each other and see the slides. Next slide, please. What we did was, and you won't be able to read this well, but was the idea of putting 1 through 4 for each of these, and to get a score and to see if we could actually score them. We're doing a better job now of actually defining what the score means. When we originally did this, we looked at sort of the whole practice, but this can be looking at the practice transformation in general, or it can be used to look specifically at the project they're working on. So, for example, we had a very high-performing practice in our CKD study that scores very high on this as an organization. But on the CKD study, they weren't doing very much because they were doing PCMH recertification, meaningful use certification. Blue Cross Blue Shield had a different PCMH than NCQA, and they were doing NCQA diabetes and NCQA coronary artery disease. So the CKD study took a back burner. So where they are to transform practice, the transformation as part of the study maybe have to be looked at a little bit differently. We also found that trying to get a better data dictionary of what target or reminders mean so we can get some inter-rater reliability is what we're working on now. So this is an evolution, and you know, if you have thoughts, please give them to me for feedback, because we're evolving this to try and hone the tool and make it more specific. Next. Here's some examples from our study of what happened on individual practice, and this was just with global scoring. And it was very interesting to see this graph, because just look at practice 1. It went from the top performing practice to like the 5th or 6th. It turns out that they changed their computer decision support program, and their new computer decision support program wasn't working yet, which is a lot of the reason why they had dropped. So that made perfect sense. And then there was another practice, practice 4, that dropped No, it wasn't practice 4. Let me see which one it was. Well, I can't find the specific one. Another practice dropped very much, but that practice lost their office manager, their lead biller, and it was a solo internal medicine practice, so their office staff was in total chaos. So they were not doing as well, you know, as a practice. And then look at the next slide. So if we looked at all the practices together, there was definite regression toward the mean. They looked about the same before and after. So we saw a lot of variation where practices, some practices did better and an equal number of practices did worse. But on an individual practice level, we were able to pinpoint that through some of it. Next slide, please. So here was some of the examples where those were the two practices. The first one where the first one I described that didn't do as well, their targets dropped off because they lost the computer decision support, and that last practice that dropped off markedly because they had lost their staff. Next slide, please.
Dr. Fox, that's the last.
I'm done, so I'm finished. So can you launch the polling question?
Sure. One moment, please.
So while they're launching the polling questions and folks are responding before Dr. Nemeth speaks, Dr. Fox, something to think about, as maybe we'll have questions at the end in the interest of time, was primary care practice-based research networks. Of course, you're presenting a predominantly primary care experience. At the conclusion, if we could think about how this particular approach could also be used for other healthcare settings, even for clinicians who are not seeing patients directly. And in the meantime, folks are responding to the question with respect to, have you identified experience using an implementation survey to identify areas on which to focus transformation efforts? And so about half of the folks are voting. Again, I encourage people to vote. This is one way by which we track that we have folks engaged and really can demonstrate the need for these types of coming together. And with that, we'll turn it over to you, Dr. Nemeth.
Well, thank you. I'm glad to join you today. My talk is going to be about measuring practice transformation in PPRNet, which is a network of many practices all across the country. Next slide, please. I'd like to acknowledge my co-investigators, Dr. Stephen Ornstein, who is the founder of PPRNet, Andrea Wessel, who is our pharmacist on the team, Dr. Kara Litman, who is an internist on our team, Dr. Ruth Jenkins, a bioinformaticist who manages data enormously well, Paul Neidert, who is our statistician, and of course the PPRNet member practices all over the country, without whom we could not have done this work. Of course, I'd also like to acknowledge our grants that have funded our work to be able to report here today. Next slide. So today what I want to talk to you about is disseminating a conceptual model for improving primary care using health information technology. I'll discuss the model concepts and practice activities that were related to this model, explain how these concepts were used to develop a survey that measures meaningful use, and consider the implications of measuring these activities to apply them for correlation with clinical quality measures, which is becoming all the more important in these days of meaningful use. Next slide, please. Okay, so the Synthesizing Lessons Learned Using Health Information Technology study was a secondary analysis of 7 prior PPRNet studies that were conducted within the decade 2001 to 2012. Those studies originally took a look at cardiovascular and stroke prevention, alcohol screening and brief intervention. There were actually 2 studies on that. A broad set of primary care measures, colorectal cancer screening, medication safety, and standing orders in primary care. 134 practices nationwide participated in this collaborative learning community, coming together with annual meetings and, of course, our visiting them, site visits for these specific studies. What we learned through this synthesis was that practices use health information technology and staff in new ways, and that complex interventions such as improvement in these areas noted above rely on 4 main concepts. Next slide. This is the model, and I will say as a qualitative researcher, I like to use conceptual models because I find that they are able to really pull out the salient concepts that are involved. And as you can see, using a model, you can visualize what needs to be done. So the first thing is that in order for improvement to occur, investments are needed by practices in terms of acquiring the health information technology resources, choosing the record that they're going to use, and educating their staff and clinicians, and doing the practice development to redesign systems for optimal use. Of course, this requires establishing leadership. A lot of these concepts overlap with what Chet Fox just described. You can't do this without having a clear vision and leadership that goes along with that. Practicing team care is an important component, and that requires a complete transition. And of course, adapting and using H-IT tools to their maximum ability will help practices actually transform their practice culture and quality, because they will start to have the data that they need to be able to work on activating their patients. This ended up leading to improved outcomes in their quality measures. We were in PPRNet providing and have been providing quarterly reports to practices on a large set of primary care measures. As well, these apply to NCQA measures or CMS, meaningful use, etc. There's so many measures that are now required for practices. This is a very important issue for everyone. And what comes out of this is rewards. Staff and providers were seen as being more satisfied, and practices were reaping financial alignment with quality measures that were successful. Next slide, please. So taking a look at those concepts, I wanted to break them down so that people can see exactly what was being undertaken by these practices during these specific studies. As I mentioned, this is related to 7 particular studies. And so looking across this grid, you can see how practice team care, how adapting and using health information tools, transform practice culture and quality, and activate patients actually progressed almost cumulatively over that decade with increasing sophistication. Not all of the practices in these studies were the same. Some were and some weren't, but some practices that had more experience with our early studies progressed and developed a real savvy sophistication of being able to use advanced templates. You can click through all of this. Please advance. Yeah, just quickly click through. You can see that these are all differently related approaches that were related to these studies. Thank you. And I think that when you get the slides, you'll be able to see those particular activities again in more detail. But I won't spend a lot of time going over that now, since that could take a whole day. Well, we needed a measurement tool. We had, I think, a useful model, and the meaningful use study that was being requested by AHRQ about 2 years ago now. I think it was March of 2013. that we were asked to actually submit a study, and there was a very fast turnaround time. Was it March 2012? We were to finish it March 2013, and we started our study in September of 2013 and finished it in May of 2014. It was a 9-month study. We were to evaluate meaningful use stage 3 clinical quality measures for their relevance to primary care. We had 21 measures in which we selected that were part of the PPRNet, or very close to what PPRNet was already measuring. These measures aligned with population and public health, clinical process and effectiveness, and patient safety and efficient use of healthcare resources in the proposed meaningful use stage 3 CQM set. Our research team then developed a survey using 5 iterative rounds of development to take a look at how practices were able to substantially engage or meaningfully use their EHR. So to develop this survey, we mapped each item to the CQM domain as above, whether or not they were a population, public health, clinical process, or patient safety measure. We also mapped them to the improving primary care through H-IT concept that I just showed you, and we also mapped them to the consolidated framework on implementation research domain, since that was becoming the most prominent implementation science available. Next slide, please. Taking a look at the development a little bit further, the IPC concepts of practice team care, adapt and use H-IT tools, transform practice culture and quality, and activate patients, as well as these 5 CFR domains, characteristics of the intervention, outer setting, inner setting, characteristics of individuals, and process of implementation. These were the domains that were used to construct a survey that would actually measure implementation of meaningful use. Next slide. So what the questions look like were pretty much like this. For the 21 clinical quality measures, we had questions that related to these specific areas. For example, do you agree with the following clinical quality measure? What proportion of your practice's clinical staff members are educated on specific quality goals for the following? And that those, again, included your clinical process and effectiveness and safety measures. We asked, are practice clinical staff by standing order to order or perform the following according to those measures? We asked, to what extent does your practice use EHR reminders such as flags, health maintenance, or note templates with prompts as decision support to help meet the quality goals? And to what extent does your practice use EHR embedded tools such as web links, templates, or letters for patient education that reinforces the selected population management or public health goals? Next slide. So we found some interesting associations with these CQMs. On those 5 areas that we just discussed, those key questions, regarding provider agreement, in the multivariate analysis, of which you can imagine there were many variables, there were over 100 questions in this survey. Provider agreement and colorectal cancer screening were associated. In terms of staff education, we found associations with breast cancer screening, nephropathy screens, and diabetes, the use of aspirin in ischemic vascular disease, and in the use of a depression screen. In terms of EHR reminders or decision support, we found breast, cervical, and colorectal cancer screening, the nephropathy screen, heart failure, ACE, ARB, and beta blockers were associated, as well as chlamydia, depression screen, flu, and pneumonia vaccines. Now, standing orders, interestingly, while there were many associations in our bivariate analyses, none were found when controlling for CDS use, which we understood it as they're both really critically linked. Standing orders were critically linked to the EHR reminders. And EHR patient education, we found associations for cervical cancer screening, hemoglobin A1C control, and heart failure use of beta blockers. Next slide. So we feel that future research is needed. This Exemplars of Meaningful Use survey that we developed needs further testing to become more widely available to measure transformation. We also noted that a quantitative measure can be used to further test associations of practice strategies with clinical quality measure performance. And we have still remaining questions. We need to understand how practices can best make improvements, and the use of these core strategies may signal specific areas that can be used to address the goals. So with that, I thank you very much for your attention.
Thank you, Dr. Nemeth. Is there going to be a more in-depth presentation for folks who are going to NAPCRAC by Kara Lipman of your
Yes.
meaningful use? So
Absolutely.
You can take folks who are going to NAPCRAC and look at the agenda for follow-up. Please, folks, continue to use the posting of questions. And we'll go on to Drs. Nagykaldi and Lipman, and we'll look forward to some questions and answers with Dr. Fox and Dr. Nemeth as after we've heard from a few more presenters. Thank you.
Good afternoon. It is a pleasure to talk to you today about a practice change model that our team has developed and successfully implemented in a number of past projects. Next slide, please. Let me take a moment to acknowledge the contributions of our excellent and well-rounded team representing 5 PBRNs, Westat team led by my co-presenter, Dr. Lipman, acting as our study coordinating center, and Dr. Leigh Solberg, who provided essential input into the development of our model, and of course AHRQ that supported our project. Next slide, please. In a seminal paper published in 2007 by Dr. Leigh Solberg, described as a straightforward conceptual framework, which was derived from his web of personal experiences and the literature, that can help primary care practices and conceptualizes the process of practice improvement. The strengths of the model include a specific attention to the context of individual practices and the inherently complex details of primary health care and an array of confounding factors. The Solberg model focuses on 3 domains or factors that are all necessary for successful practice change. If you could advance the slides, I think you will see some of the arrows pointing. Thank you. Appreciate that. Priority of improving the practices in a particular area is essential. Without it, the change process can't even be initiated. Solberg compares priority to a burning platform that represents an entire organization permeated by the desire to improve what they do. Change process capacity is the organization's innate ability for completing a specific change process. Capacity may include effective leadership, appropriate infrastructure, skilled personnel, a high degree of trust, individual accountability, and organizational engagement. Change process content incorporates all steps that result in system-level care processes and their improvement. These care processes and these areas are described in Wagner's chronic care model, including delivery system redesign, self-management support, decision support, and health information systems. And I apologize, the slide is a little bit crunched, so you can't see which arrow goes where, but on the original it is clearly seen. More recently, Solberg's model was extended and operationalized by our team led by Dr. Jim Mold and others at the University of Oklahoma. elements of Solberg's conceptual framework were matched to actionable implementation components that together form a reliable and reusable practice improvement approach in primary care settings. These components include ongoing practice performance feedback, benchmarking, academic detailing, practice facilitation, local learning collaboratives as an option, and health information technology support. Very similar to those elements that we heard before in previous talks. Based on this experience, and each practice improvement process component was linked to one of the Solberg factors, practice facilitation being a powerful component that affects all three factors, while performance feedback and technology support may have a more focused impact on individual factors. Some examples for actual activities are listed on the slide. Next slide, please. Let me give you an example for the application of the Solberg-Mold model based on an actual OKPRN study. We recently completed a chronic kidney disease guideline implementation project, which was funded by AHRQ, and it aimed at the implementation and dissemination of CKD guidelines in multiple PBRNs. The implementation was initiated by academic detailing visits that facilitated a respectful conversation about current evidence and practices pertaining to CKD care in ambulatory settings. We then provided ongoing performance feedback to practices on specific measures that were highly relevant to CKD management and reviewed the progress of each participating practice toward the attainment of their goals. We provided practice facilitators who have worked with these practices systematically to tailor system-level interventions to their environment. We also provided various levels of technical support. For example, we enabled EHRs to automatically provide estimated glomerular filtration rates. Finally, we use locally and local learning collaboratives in the first wave of early adopter practices, either through physical or virtual meetings, to facilitate the diffusion of successful interventions to a second wave of 32 practices. At this point, let me introduce my colleague, Dr. Paula Lipman, who will explain how we measured organizational change and the improvement of CKD management in these practices.
Hi there. Thank you, Zsolt. So Zsolt has introduced the model and also described briefly our CKD project, in which we incorporated a measure of change process capability. And as part of our study design, we were interested in determining whether the interventions that Zsolt mentioned, primarily practice facilitation and practice facilitation compared to local learning collaboratives, impacted change process capability, and whether the results were the same across what we call the waves, these two different interventions. So how did we go about doing that? So we measured change process capability using the Change Process Capability Questionnaire, referred to as the CPCQ. And this instrument was originally developed by Solberg and colleagues to measure an organization's ability and readiness to measure change. So originally, the instrument was developed with the assistance of experienced quality improvement leaders who identified 30 factors and strategies they thought were most important for successful implementation. And in that study, they did find a relationship between survey scores and depression improvement. So this study focused on depression. Okay, next slide, please. So I'm going to provide a description of how the constructs that Zsolt introduced, priority, organizational factors, and strategies, were measured and applied in our project. So the CPCQ instrument itself has 30 items measured on a 5-point Likert scale, ranging from strongly agree to strongly disagree. And that's sort of the organizational factors. Priority was measured by one item on a visual analog scale, and the question was posed, considering all the priorities your clinic has over the next year, what is the priority for your clinic to improve the targeted care, and in our case it was chronic kidney disease care on a scale of 0 to 10. So that was our measure of priority. Organizational factors, there were 3 subcomponents: previous history of change, plans for organizational refinement, and ability to initiate and sustain change. So, as I mentioned, the instrument is tailored to the particular targeted outcomes. So ours focused on chronic kidney disease versus depression. And finally, there's strategies, and these are very specific approaches to managing change or to adoption of the improved targeted care. So, for example, periodic measurement of performance or delegating physician work to non-physician staff. And there's a list of about 16 of those, and the lead clinician was asked to indicate whether they implemented this to improve chronic kidney disease care. If they did, yes, did it work well, or not, or no. And these data were collected before and after the interventions from the lead clinician. Next slide, please. So the first aim of the CKD study was, in fact, to look at the feasibility and effectiveness of our Wave 2 strategy, and so it's stated as aim 1, determine whether the early adopter practices in Wave 1 could recruit additional practices, Wave 2, to implement the CKD guidelines and facilitate the implementation process. In fact, most of the Wave 1 clinicians were able to recruit 2 additional practices to work with them for the 6 months of local learning collaborative meetings. And in terms of clinical care outcomes, the Wave 1 practices did increase use of ACE and ARBs. There was discontinuation of NSAIDs, increase in testing for anemia, and testing or treatment of vitamin D deficiency. And so those are Wave 1 outcomes. Wave 1 practices received weekly practice facilitation. The Wave 2 practices participating in the local learning collaboratives also had some significant improvements, more specifically around ACE and ARBs and testing or treatment of vitamin D deficiency. Next slide, please. So aim 2 is more specifically focused on our use of the CPCQ, and that aim is to determine whether the change processes used by the Wave 2 practices would be the same or different from those by early adopters. So, and the differences between measures of priority, change capacity, and care processes between baseline and post-intervention were estimated using a paired t-test. So basically, we found that priority for improving care of patients with CKD remained relatively high, so it was high at pre-test, and there was basically no pre-post change. We also didn't find any significant change in the subscales that were measuring organizational factors. What we did find, however, was an increase in the number of change strategies, basically the strategy count, for Wave 1 practices only. Next slide, please. So in conclusion, we did learn that the CKD project was able to, in fact, increase the number of implemented strategies for practice improvement as delineated by the Solberg-Mold QI model. It's feasible to effectively operationalize this model in quality improvement projects and primary care practices. And the diffusion, this is back to our study aims, was generally considered to be passive. We found that it could be facilitated by PBRN researchers and member practices using a combination of strategies. Again, Wave 2 practices did show improvement in care of CKD patients, as did those Wave 1 practices, but with less practice facilitation assistance. And in summary, we believe that the PBRNs are well positioned to replicate this process for other evidence-based innovations. Thank you very much.
So I have a question for Zsolt and Paula. Could you please elaborate on how the local learning collaborative meetings were constructed and whether the organizational strategies evolved over time based on the local learning collaboratives?
Let me respond to the first part of the question. So we either geographically clustered 3 or 4 practices that came together and discussed the progress of their implementation, thereby helping each other, facilitating a cross-pollination of good ideas, but also introducing a little bit of the element of competition, friendly competition, which is not so much within the facilitation model. So it's a component or added component of the facilitation model. And some practices were far enough so that we had to use video conferencing. But these meetings basically were constructed to share war stories, tell about successes, teach the other, help the other practices improve based on your experience. I'll let Paula respond to the second part of the question.
What was the second question, Rebecca?
Did the organizational strategies, did you measure changes in organizational strategies that may be informed by the learning that's going on between the learning collaboratives and the practice facilitators? Yes,
we did. So we did collect a great deal of process data, if that's what you're referring to, where so we asked the practice facilitators who were very instrumental in organizing these meetings and leading the agenda along with the Wave 1 clinicians. We did ask them to complete a standardized form where they indicated what particular guideline the practice was working on and what were the challenges and so forth. So we do have that process data. It's been presented in different formats, but not published at this point.
Thank you. And you talked about the CPCQ instrument, which is the historical qualitative instrument. Is that still publicly available? Question 1, and question 2 is, has it evolved over time?
Well, I assume that, yeah, Leif Solberg was one of our consultants on our project, and I believe that instrument is publicly available. I don't know that the items have changed over time. I just want to point out you do have to customize it to make sure that it addresses your particular quality improvement target.
On the first question, the AHRQ 18 requires all the people to use the CPCQ, so it is publicly available. I do not know if it's changed.
Okay, thank you. We can provide that to all the folks on the call. And the question always comes up, well, we have access to these wonderful PowerPoint slides, and we will send them out to you at the end of the call, as well as once an integrated audio-visual video is available on the AHRQ YouTube channel. We'll send that to you as well. So, Dr. Kessler, you will provide us our 5th presentation. Thank you.
Thank you very much. Let me just say that I am very honored to be part of this panel. And
Dr. Kessler, it seems
can you present the next slide?
Sure.
Next slide. Thank you. So we are presented with a number of conundrums. The first is it's very difficult to turn this way or that, whether we're talking about policy or whether we're talking about research, without hearing that there is a critical role for behavioral intervention or mental health and substance abuse intervention within primary care settings. The conundrum is that there are currently at least 2 silos that make that difficult. The first is that very bright, talented clinicians have generated a variety of enterprises to collaborate in primary care with primary care physicians by co-locating behavioral health clinicians. The second is there is an equally bright set of researchers and research literature of behavioral medicine and health behavior that identifies a significant evidence base through intervening with medical patients in primary care. The largest conundrum is they are siloed, and there's very little of the evidence of behavioral intervention in primary care that is currently part of many of the efforts to do collaborative or integrated care. I would like to suggest that the issues in this panel talking about primary care transformation are pretty much the same for the movement of behavioral health in primary care if a mature field is going to develop. There are measurement questions at the patient and practice-based level. There is a movement towards panel-based focus on complexity, which I will discuss in a little bit. There is the need for transparent bidirectional EHRs that have extractable fields and can be used to meet MU3 criterion. And there is a great need for the implementation of science-driven evidence-based care that is currently mostly, well, if not mostly, considerably absent. Next slide, please. So to amplify those points, in a recent paper, which is a summary of a survey that the NRN, the CCRN, and NCQA did of the state of behavioral interventions and behavioral health in primary care settings, there were only 40% of practices identified that had a behavioral health clinician, and almost 50% of them were case managers and not behavioral health clinicians, and there was meager representation from substance abuse clinicians. We noticed that referrals, tracking, scheduling, information sharing are certainly well less integrated than for other medical subspecialties. There are only limited presence of behavioral protocols. Not even 2/3 were reached, identifying obesity, insomnia, and headaches that were limited. Thus, the notion that we are talking about co-located care rather than truly integrated care. Next slide, please. So I'm going to talk about this more in a bit, but over the last 3 years, we have developed the Vermont Integration Profile, which is a derivative of C.J. Peek's lexicon of collaborative care, and it measures 8 dimensions of collaboration that were drawn from Peek's work and adds a total score. What we wind up seeing is a distribution on the measure that suggests that the median score for all of the 90-plus practices that we have measured thus far is just a touch under 50%. So once again, not exemplars of highly integrated care. Next, please. Next slide, please. And what we're seeing is, with a small N, admittedly, that we will report out larger N's as we generate the information, the perspectives of multiple people within the practice are fairly fairly similar to each other. Thus, there appears to be consistent looks from both behavioral health clinicians and physicians about the scores. Next, please. So there is, in fact, a template for how to move. Cathal, degree in Rollman, in Annals of Family Medicine, argue combining clinical and financial benefits into one payment pool. Because the resource will be outstripped by the need that we should target complex patients for priority behavioral health care. Behavioral health needs to become part of the primary care team. The expertise needed to practice in behavioral primary care behavioral health appears to be distinct and different than other behavioral health practice, and training the workforce winds up being a conundrum. And we need to define, measure, and systematically pursue outcomes. using evidence-based treatments as the things that we want to evaluate. Next, please. So part of our response to this was to develop the Vermont Integration Profile, measuring the clauses that were identified in Peake's original lexicon. And as you can see, the dimensions, actually there should be a space between model and identification, but technology stuff happens. So we're looking at what do workflows look like, what are workspace, what are the clinical services provided, what are the model of care, how do organizations identify need, how do practices respond to patient engagement, what's the status of shared care plans, and how are patients who have been identified followed up. Next, please. And I hope that this is at least a little bit interpretable. Those 8 dimensions that I just mentioned are graphed here. And what we will notice is of the 8 dimensions, only 3 score above the 60th percentile. Let me say that again. Only 3 have medians above 60%. And the remainder meant less, and in some cases the medians are as low as 20% of respondents. Next, please. So what we're trying to do in response is to create an evidence-based pathway for an integrated primary care intervention for type 2 diabetics who have been consistently outside of control. It uses patient-reported outcomes. In our case, we're using my own health report and embedding this within the EHR to plan for and deliver care. Patient risk data become registry functions to assist in identifying patient cohorts, and this data is collected out of practice and identifies patient willingness to work on identified risk. The product within the EHR is to be a CMS wellness equivalent goal-setting document that patients have generated the data for, identify areas that they're going to work on, and essentially generate their goals and how the activities are going to occur. And this winds up being done prior to the scheduled primary care visit, and all care coming out of that interaction winds up being part of an integrated primary care the team. Next. Next, please.
This is what I have, or this is the following one?
Thank you. Before that, so most behavioral care that's delivered, there is a significant evidence to suggest that it's minimally evidence-based even when there is evidence-based care available. There's little relationship between the primary care integration developers and the behavioral medicine and health psychology research base, and systematic process improvement focusing on primary care behavioral integration is rare, despite evidence supporting the importance of process improvement and the availability of specific toolkits and resources to integrate into primary care. Last slide, please. So thus far, behavioral transformation has not generally received anywhere near the same attention that other areas of primary care transformation. has received, but must, if in fact we're going to optimize primary care at its highest level. Until population health measurement, informatics, and systematic process improvement include a strong focus on the transformation of behavioral care, then what we are essentially left with is behavioral health co-location and not transformation. Moving on these issues towards resolution is not a technological issue or a research limitation. It's a primary care leadership and research investigator issue. Last slide. So thank you very much. I want to thank my collaborators on developing the Vermont Integration Profile and my colleagues at the University of Vermont Center for Translational Science for supporting my work and assisting in the development of the material that I just presented. So thank you very much.
Thank you very much, Dr. Kessler. So we have a series of questions, and since you're currently speaking, well, the question is posed, we assume that you're using the PHQ-9 as a PRO. How do you monitor positive responses to the 9th question?
That's a great question. If you're familiar with the My Own Health Report, two of its components are the PHQ-2 and the GAD-2, and responses to those blossom the rest of the measure if in fact it's indicated. And right now it is by an eyeball. If in fact the entire PHQ is collected, there is an eyeball by a care manager of the 9th question, and if it's positive, that's immediately reported to a primary care physician.
Great, thank you very much. And a question to Dr. Nagykaldi and Dr. Lipman. In your project, did you check whether processes were suffering while the practice focused on improving the targeted processes? Zsolt and Paula?
I am not aware. I don't think we did. Paula, do you remember?
No, I don't think we did. No, that is a very important question, but I don't think we did. I mean, you know, in defense of that, I think that you know, all of the practices were highly motivated to improve chronic kidney disease care, and they also knew that they were lacking in that area. You know, whether it impacted you know, other types of care, we did not address.
The other issue is the change capacity includes an assessment of the practice's readiness for change in general, which also includes the current burden on the practice. So practices in turmoil or significant change would not be good candidates for anything like this.
Great, thank you. And Dr. Fox, going back to your presentation with respect to the Translate model, could you please discuss the extent to which you came up with the numerical evaluations for the different stages of the Translate model for the scores?
Yeah. What we did, I tried to model it sort of after the PHQ-9 rather than a 5-point, just a 4-point scale. So for each of them, we thought about what would be sort of the ideal to not at all. So, for example, for goals, it went to either no goals set or too many goals to clear, measurable, and feasible with gradations in between. For administrative buy-in, it went from resistant to enthusiastic with 2 gradations in between. For reminder systems, it went from the inability to create a reminder at all to having reminders but not using it, having them used minimally or having them used frequently. Ditto for networked information systems and registries. For site coordination, whether someone was identified and whether they had adequate time to do the work. So it went from no one identified as a site coordinator someone identified but given no time, someone identified but given minimal time, and someone identified and given all the time they sort of need. Audit and feedback was, whether they got the reports and how often they looked at them, and whether they distributed the reports. Team approach on whether they had team meetings, and education on number of educational. So it is somewhat subjective. We're trying to make it more objective in terms of how we do it, but that's how we came up with it. If I could go back to your other question, the translate model will work for, even though it's just been used in primary care, those same 9 elements will work for hospital physicians and other things. Are there goals? Do you have the data? Do the physicians buy in? Is there site coordination? Is there feedback? Is there training or education? All those 9 principles will apply to any, I think, transformation or quality improvement project. So I think it is, no pun intended, translatable beyond primary care.
Great. Thank you, Dr. Fox. So I have a few more questions that I will verbally give to the responders, but I really ask you, I'm going to activate 3 polling questions that really talk about this type of meeting place that we have, the national webinar. And then later when you exit, there will be an opportunity to evaluate the particular content of this presentation by these 5 thoughtful experts in their fields. But for a long time, the PBRN community has had national webinars and elsewhere, but we really need to demonstrate and understand and prioritize the type of convening media that we support, with limited resources. So you be honest with us, but I'm seeking whether or not you found this, well, they'll be self-explanatory as far as the question. So I rely on AHRQ PBRN Resource Center to address PBRN needs not otherwise addressed elsewhere, and then you can choose your perspective. And in the meantime, Dr. Nemeth, a couple questions were posed with respect to your presentation, one of which was, might the Meaningful Use Survey be available? And the other question was respect with, you did present different analysis, and you had so many variables, and you did address some lost meaningfulness in larger series of analysis, but could you talk about how you determined whether or not a finding was actually meaningful when so many explanatory variables were considered? Thank you.
Thank you. Well, I think overall, we think these are meaningful because we measured this in a large set of practices nationwide, 71 practices that had 92% response rate from the clinicians that participated there. So we had a significant enough sample that we were drawing from. These were practices that had sufficient experience in using electronic health records, and so we felt that, and have participated in actually the development of the strategies. So they were knowledgeable about the strategies. They weren't taking the survey cold without any prior experience. So we felt that made our associations meaningful.
Well, thank you. Let's see what other questions. I'll open it up. Do you have questions for one another? Because I know that this presentation is evolving over time, and it has generated discussions amongst all 5 presenters. We'll just, Dr. Fox, is there something else that has resonated with you in hearing the presenters today? Or a question to them? Any of your colleagues?
I was struck by, a lot of us are getting at the same sort of things from different angles. Did any of you see a way that we could sort of meld this? In other words, adding some of the academic detailing and the change capacity into, say, the translate model, and at the same time, how that might fit with Lynne, with your model, you know, or how your model might integrate with either Zsolt's or mine.
It seems that there, in my mind, and I appreciate that question, Chet, that there's tremendous overlap on a number of the concepts here, especially since we're all measuring primary care transformation. And as some of our audiences pointed out, that these may not be applicable to other areas. So I think it would be worth our looking to see whether or not there's parsimony in setting more of a consistent model for approaching this transformation.
Great, thank you. And Zsolt, is there any question you'd like to pose to your, or reflections you'd like to give to the group?
I agree with Chet that on the practical level, the steps and strategies are very similar, and there's perhaps a reason for that. We are learning together as well nationally as a learning community, but it would be good to look for the opportunity of unification.
And Paula, Dr. Lipman, what would you like to bring to the discussion as we close?
Yes, I'd just like to point out that when we go back to the findings from our CKD study, in fact, we did not find any change in capability except for the strategy count, as I reported earlier. You know, it's not clear to me exactly how to interpret that, but I think one of the things that we need to think about when we are measuring change is the timing of measuring change. I think that's really critical. I mean, we know that there were changes that took place in these practices. It's possible the CPCQ is not the best instrument, but I think there's other methodological issues that are important to consider.
Thank you. So with that, I'm going to launch one more poll that really has to do with this type of venue. How frequently, for those of you who have been on a PBRN resource webinar before, how frequently do you apply the lessons learned from these types of webinars? Or not at all frequently, somewhat frequently, frequently, and very frequently? So Dr. Kessler, when you in behavioral health, were there particular challenges that you had because of the topic in your area of expertise that we need to be mindful of?
Thank you. I think the key issue is behavioral health is consistently treated like a carve-out. And it's always when we have the time and energy to get to it. And what I continue to search for is a way to carve behavioral health back into its place in planning and executing care and monitoring outcomes. Because, for example, if you have type 2 diabetics that are out of control and the primary interventions are pharmacologic, medical, or a physician telling somebody what to do, the probability of generating outcomes without an integrated behavioral intervention to assist people in doing what they need to do is a failure mode. So to reiterate, it's about behavioral issues becoming part not of a behavioral health carve-out in the practice, but rather the core of medical care.
Thank you very much. And so I want to thank our thoughtful participants out in the hinterlands who posed very good questions. I want to especially thank the 5 presenters. It's rather challenging to have 5 extremely well-versed and in-depth presentations. And I appreciate their working with one another and their individual advancements of this measurement area. And Christina, could we tell people, advance the slide so we can tell people what's coming next with respect to the PBRN?
Sure, and actually I'll just launch the last evaluation question, last poll we have, and then I'll go ahead with that. Those final slides.
Well, that is closing. I'd like to echo Rodger's thoughts on the importance of having behavioral health integrated. I can think of an area where we know a lot of us in primary care are struggling with the whole chronic pain and use of opiates and insomnia and other things, and we know that there are effective behavioral health interventions that would probably help in both those areas, yet they're not really accessible to us.
Great, thank you.
Thank you, Chet.
And thank you to the participants for for voting in the last poll. So just very briefly now, I'd like to share that this live series has been approved for 1.25 elective CME credits. So to obtain these CME credits for your participation, please complete the online evaluation of this webinar, which you'll be prompted to do upon exiting. And then please email pbrn@abpassoc.com if you would like to request a copy of your CME Certificate of Participation. For additional practice facilitation resources, please visit the AHRQ PBRN Resource Center webinars, which we have held in the past, AHRQ's Patient-Centered Medical Home Practice Facilitation page, or and please, we invite you to subscribe to AHRQ's Primary Care Practice Facilitation Forum newsletter, and information on how to do so is listed on the slide. We also invite you to participate in our upcoming December 11th PBRN Resource Center webinar featuring Dr. Kevin Thorpe, and he'll be sharing a presentation on the PRECI tool, Understanding Your Research Intentions, the Pragmatic Explanatory Continuum. Last, we asked you to join the PBRN listserv where general announcements of interest to PBRNs are posted regularly. To do so, please email us again at pbrn@abpassoc.com. Thank you so much for attending today's PBRN webinar. Thank you to all of our presenters. And this concludes today's webinar.
Thank you all. Have a nice Thanksgiving.